Thank you very much. I'd like to thank the organizers for inviting me here today, and maybe this is one of the explanations of what happens in remote preconditioning. So I'm going to talk to you, since I've only got 10 minutes, fairly rapidly about our experience with circulating progenitor cells and what we think is going on. So this is what I'm going to cover. There are progenitor cells that circulate in our bloodstream that can be measured fairly accurately. And there are differences in cardiovascular syndromes and what they are able to designate or predict, which I'll mention a little bit. So just to orient you, a bone marrow houses plenty of stem cells and progenitor cells that can be differentiated in these different lineages. And the ones that I'm going to really concentrate on are these progenitor cells that are hematopoietic or endothelial progenitors, which are derived from the mesodermal lineage, that circulate in enough of a quantity that they can be measured fairly accurately. But there are, of course, many other progenitors, mesenchymal, et cetera, that are relevant in terms of cardiac healing and repair, et cetera. As well, that may circulate in such small numbers that they are very hard to measure. So it's the CD34 subset that we have been interested in that I'm going to show you most data on. This is measured by this technique called flow cytometry, where mononuclear cells are labeled for CD45 negativity, and then CD34 and other subsets of CD34 cells are counted. And the ones that are of interest as progenitor cell populations are cells that express CD34, which are thought to be enriched for hematopoietic progenitors, and then cells that, in addition to expressing CD34, express CD133, that may give us an impression of how many are immature, sort of early cells that have left the bone marrow, and then others that also express VEGF receptor, which these cells are far less frequent compared to these, and these are thought to be even further enriched for endothelial progenitor cells. And then also for expressing CXCR4, which we mentioned earlier, is a receptor that homes these cells to areas of ischemia which are expressing STF1. So this whole concept of the cells coming out and going to ischemic area and homing there is manifested by the expression of this receptor. There's a lot of experimental data to support that these CD34 cells are not only there, but they are able to repair and heal. So they are able to grow new blood vessels and in the experimental settings of ischemia. So this is an experimental model of myocardial infarction where low numbers of mononuclear cells have been given, or high numbers, and then CD34 cells which have been extracted from this population so that they are pure CD34 cells and not mixed in with CD34 negative cells. And you can see the capillary density is best increased by this group of cells, even though this high mononuclear cell population produces some improvement with equal number of CD34 cells. So there is something about CD34 negative cells that detracts from repair and so on. So and if you look at infarct size, etc., the rest of the experiments go along with the fact that these cells have the capacity in the setting of ischemia infarction to cause neorevascularization to occur. So in the circulation, these in the bone marrow, these constitute about 1 in 1,000 or so cells. If you label them and see where they go in terms of infarction, in a setting of infarct, you can actually measure the numbers of cells that get there and how long they stay there, etc. But it's been shown that if you do so with mononuclear cell population from the bone marrow, about 1 to 2% get there. But the CD34 select population, much more than that, almost tenfold more cells actually get to the infarct zone, suggesting that the expression of the other receptors like CXCR4 allow them to home to areas of ischemia. So that's a little bit of biology about these cells. Now these cells, as I say, circulate in enough numbers that using FACS analysis you can measure them. And what I'm showing you here is several hundred patient data or subject data of relatively healthy individuals ranging in age from 18 to over 70. And men are shown in green and women in blue. And as you can see, if you look at these populations, these are CD34 cells, these are CD34s also expressing 133, these are expressing VEGF, for example, but generally the trend is that as we get older, we have less of them in the circulation, and women at all ages have less. So you get less, or we have less of them as we get older. And there is a difference into if you're aging in a healthy way as opposed to unhealthy way as well. Now, the other things that we looked at were conditions of ischemia. So here are patients who came in with acute coronary syndrome. Some of them had unstable angina, some had ST elevation MI, others had non-ST elevation MI. And we enumerated these cells and compared them with people with stable coronary artery disease who were not being measured in this setting of acute ischemia. And basically what we noticed is that these VEGF-expressing cells are increased in number in these ischemic situations. Whereas these other cells, the CD34-133 population, which are mainly hematopoietic progenitors, are not similarly increased. So it's the VEGF-expressing or endothelial-enriched populations that appear to be mobilized more in the setting of ischemia, which is also shown on this slide. We have other ways of inducing ischemia, which is relatively subtle. There are studies that have already been published showing that exercise testing ischemia can also mobilize these cells. We have another protocol which is examining something else, but where we induce mental stress-induced ischemia. So this protocol is that over 3 minutes, patients are made to make a speech on a subject that is not pleasant to them. There's a little role playing that they have to do, and there's a camera in front of them, and there's sort of strangers standing around, and they're made to make the speech. It only lasts 3 minutes. But during that, there is a huge hemodynamic change. The mean increase in blood pressure, systolic pressure, for example, is 40 millimeters. And a number of them, people with coronary disease, will develop ischemia during these episodes when they are making a speech like this. But interestingly, when we looked at progenitor cell levels in mental stress, pre and post mental stress, there's almost a 21% increase in circulating levels of these VEGF-expressing progenitor cells just by the act of making this speech for 3 minutes. And then if you look at individuals who are positive for ischemia by a nuclear scan versus those who are negative, then these people have just baseline more cells in their circulation than these other people. So these, presumably they're going through these episodes of getting angry during the day or upset and are getting a little bit of ischemia. It's almost always silent, and that this is enough to mobilize their cells in a continuous way. There's another group of people that have very subtle ischemia. These are women who were enrolled into the WISE study that many of you might be familiar with. This is Women in Ischemia Evaluation Study. These are generally women with chest pain and near-normal coronary arteries, don't have much obstructive disease, yet on testing their circulation and the microcirculation with adenosine and so on, they have microvascular abnormalities such that their microcirculation doesn't vasodilate as much as others. So people who had CFR abnormalities had more cells compared to those who didn't. So there was mobilization of cells in relation to this flow reserve abnormality. And a similar abnormality and similar trend when we looked at endothelial dysfunction in the coronary circulation. So people who had an abnormal response to acetylcholine, meaning had a lower increase in flow with acetylcholine, had more cells, these VEGF-expressing cells, compared to those who had a normal response. So what this data suggests is that acute coronary syndrome is associated with mobilization of VEGF-expressing and CXCR4-expressing progenitor cells, and that subjects with microvascular coronary ischemia with reduced flow reserve and endothelial dysfunction have higher circulating levels of these cells, and that these cells that express CXCR4 are the cells that have the capacity to home to areas of ischemia are increased in those who develop ischemia even during mental stress. So this suggests that even mild ischemia during daily life is able to stimulate circulating numbers and circulation of these cells in increased numbers. So as we collected more of this data, one of the big questions we wanted to know was how this would change our thinking. So our standard thinking is that risk factors lead to endothelial injury, that leads to dysfunction, that leads to atherosclerosis, and then to cardiovascular events. But now we know that all of this is actually a stimulus for our bone marrow and local tissues to release repair mechanisms, which are what these progenitor cells presumably are telling us. So every time you injure something, there is a release of these cells into the circulation, and their job is to repair. and part of their job is to repair the vascular damage that's occurring. So there is constant damage and repair, and it's the balance between the two, presumably, that leads to disease. So at least this was a speculation when we started this. So in order to answer this question, what we had to do was to collect a bunch of people where we measured this and followed them for cardiovascular events. So these are people who are undergoing coronary angiography. So a lot of them have coronary disease, which is significant. A lot of them have insignificant disease. They're going to the cath lab. So consecutive individuals, almost 900 of them, were recruited over a period of time, and then they were followed. And we enumerated these cells like I showed you earlier. In mononuclear cell population, we looked for these epitopes and counted them. And they were followed for there were 2 cohorts. We did the first one, and then we did a second cohort just to confirm the findings of the first one. And they were corrected, all these results, for baseline characteristics. So again, for sake of time, I won't go through each of these. But if you look at the pooled data of 900 plus subjects, these are people who had higher numbers of circulating progenitor cells, CD34 positive, and these are CD34 and 133 dual positive, but a significant difference, almost a 2.5 to 3-fold increased risk of having death or MI going forwards in the next year or two if you have high or low numbers of these cells. So people who had higher numbers of circulating progenitor cells survived much better than people who didn't, even after correcting for everything under the sun that we could. And it improved the C statistic from standard risk factor dependent prediction from 0.71 to 0.75, which was significant. And this just shows you odds ratios for CD34 or 133 or CXCR4 expressing cells, almost a 2.5 to 3-fold increased risk of death MI or death or cardiovascular death, depending on what you wanted to look at. And really there was no heterogeneity between different groups, whether male or female, old or young, MI, no MI, diabetes, no diabetes. So the conclusion was that low levels of circulating progenitor cells, defined in this way, are robustly associated with risk of future death and MI in people with coronary disease. And the implications that these cells are enriched for bone marrow-derived hematopoietic and endothelial progenitor cells and may represent an index of global regenerative potential. And that progenitor cells protect or regenerate damaged endothelium by local and systemic paracrine effects, and that this predictive value of progenitor cells as risk markers was equal or greater than some of the conventional risk factors like diabetes and smoking. And this has now been taken to a different level as a therapeutic potential. There are clinical trials, as you know, going on in acute MI setting. There's a phase 2 study that we're involved with, which is about to finish recruiting, where large numbers, millions of CD34 cells have been given post-STEMI to look to see whether this would be of benefit. So in the end, the paradigm that I would like to suggest is that this is increasing age and increasing incidence of atherosclerosis that we observe in us, in the population. So we are exposed to all these many risk factors, often starting at a very young age, same high cholesterol and smoking and what have you. But all this time, as we're young, we have these cells that are being mobilized from our bone marrow. They go out there, heal and repair, and then we don't get disease. But then we get to a point where these cells actually run out. You saw that even in the healthy population, there's a decline of these cells. And then, of course, they'll decline faster and further if you are sicker. And so the normal response is you expose yourself to risk factors, these cells will come out and repair, and then you won't get any damage. But then as we get older, as the progenitor cell system becomes defunct for one reason or another, and we need to understand why this is occurring, then the risk factors prevail, and then you get disease and die. Thank you very much for your attention. That's a good night.